health and science reporting for 37 years.
Yeah, or 8. Yeah.
For a number of years, he was a health and science reporter for the New York Times and the Washington Post, and then moved on to book writing. And The Arts for Survival book is his latest. So we're very lucky to have him this evening, and please join me in welcoming him.
Thank you. Yeah, the book is that blue one. The series on TV and the book cover some of the same stories, but some of them are different. And the book actually also covers things that are harder to do on PBS, which is talking about policy, talking about what choices we have now, what's going on, some of the background politics. But it also has the stories on the ground from the countries that I visited. So this is what I'm giving is kind of like a report from the field, which is sort of natural to me. I've been out working on this about 3 years and visiting countries, maybe 8, 9 countries for this project. The object when I started was to go and find out what was happening with global health issues, and particularly looking for particular projects that worked well or things that were particularly interesting. And I went out with the usual expectations about what I would find. I had been out somewhat before. A lot of poverty, a lot of disease, crowding, suffering, whatever. And a lot of things not working. But after doing this for a while, what surprised me was the other things I found. And the thing which feels most important to me now is the other things, which is really hopeful things working on the ground, projects that are actually really flying, and not little ones, very big ones, that are actually changing mortality rates, dropping the death rates a lot. Not just delivering vaccines, but actually watching the death rates come down. And the fact that those things are out there, and there's a movement building to deliver more of that. So it was kind of a surprise, and a lot of the things I'm going to tell you about are things that are, relatively speaking, new. That is, these subjects are all quite old. But a lot of the data is relatively new. Things have been studied for many, many years, but in the last 10 or 15 years, a lot of the data has coalesced in a much clearer picture, a much better understanding of what we have seen historically. So this is the sense of where we are, hope and hazard. Human Health in Global Times. Before I talk about some of the things I did in the countries and what I saw in the countries, I want to put a frame around it. This is the historical frame. The name, The Vital Revolution. I apologize for the handmade look of this thing. The reason it looks handmade is because it is in fact handmade. I borrowed my 11-year-old daughter's magic marker, and then I asked her to teach me how to use the PowerPoint so I could put the things together. This is life expectancy. And it goes back, you can see 3000 BCE here, but it goes back. Life expectancy was between 20 and 30, as far as we know, back to Neolithic times. There was no change. Suddenly, things shoot up. And this is not just the West. You'll see there's England and France here, but also Japan, India, and China. The difference being the ones who came on later, India and China and Japan, having had the advantage of seeing what was going on here, shoot up faster. So there's some economists who have written about this change in human development. And here's Robert Fogel's graph for it. He's a Nobel Prize winner in economics. This one doesn't chart life expectancy, but instead population. But you can see straight out and then straight up. So James Riley says The Great Progress, 1 billion people lived to 30 years. During the Great Progress, 1 billion people lived to 30 years, and then up to 6 billion lived to nearly 70. This is the crowning achievement of the modern era, surpassing wealth, military power, and political stability and import. Prior to the vital revolution, more than half of the people died before adulthood, and in some countries, more than half died before age 10. The attempt to control disease has evolved into one of the three most elaborate structures that people have overtly built, along with polities and economies. Of the three, the health transition, this vital revolution, has been the most successful, delivering a larger quantity of long life to a larger share of the world population than polities have delivered good government or economies wealth. Fogel says, human beings have gained unprecedented control over their environment, a degree of control so great that it sets them apart not only from all other species, but also from all previous generations of Homo sapiens. There is a new degree of control has enabled Homo sapiens to increase its average body size by over 50% and its longevity by more than 100% since 1800. So we're talking about really a new species, an evolution, although a cultural evolution. And the question, we always believed, we saw this trend fairly late, actually, not until the 1950s did we see this whole history happening. There were hints of it in the 30s and 40s that something really was going on, but it wasn't clear what. And then it wasn't until the 50s they started analyzing what was driving this. And the original idea was, first, there was wealth, investment, and because it took off in the 1800s, steam motors, railroad, telegraph, the full set of technologies, investments, the globalization boom. But then when they did the math later, Fogel did it and published it in 2000, it turned out that all of those things that we thought were the start of development, the start of the big boom that we're living in now, was in fact not the wealth and the technology. The number one item was health, the human engine, which he says, after doing massive amounts of math, was 53% of all the wealth gained in Britain from 1790 to 1980, almost 200 years. 53% of it was the human engine. That is, the change in robustness, in height, in doubling the lifespan, the amount of work going on, and education. So that people are working smarter as well as bigger and stronger and longer and so on. It's the human engine that was at the center of it. This is fairly new, this view of it. And we had based our previous policies on the other idea, that humans weren't at the center of it. So that we are at the pinnacle of a 200 and some year drive, human enterprise. We didn't really do it all on purpose, but it came out that way. We're now in a different era entirely. And what I was looking at when I was doing this project was, after looking at the basic background on health and longevity and all that stuff, then I started looking at the more modern data. And you see things coming apart, this 300-year, 250-year drive. The data, the basic data starts coming apart. So this is U.S. This is public health spending. What drove that long rise started with the projects called sanitary projects, delivery of clean water in England, sewage pipes to take it away and dump it below London, cleaning the streets, changing housing, different working conditions. That's when it started. Public health laws, they jumped from England to the continent, then around the world, both sewers and the laws and the idea of cleanliness. That's what pushed it off. And so a continuous drive in spending on things like public health until the 1970s in the U.S. when it collapsed. This is the U.S. foreign aid percentage of the budget. Also, spending, this is right after World War II, and then gradually drifting down to where we are now, which in these terms is less than 1% of the budget. The life expectancies, which had been going up everywhere around the world, they're coming down. This is 6 countries in Africa, and these are the big ones. 20-some countries have gone down in life expectancy, but these are the big drops. I lived in Botswana for a year and a half. The Botswana one is the biggest one, from about 63 years down to this one. I think it has 30-something, but it's now down to about 29. In one country over a period of a few years. People, when they look at that, they say, well, it's HIV, AIDS, it's just an odd sort of event, something weird that happened. But in fact, it's not just AIDS, and it's not just Africa. This is Eastern Europe. Life expectancy drops in Eastern Europe. 8 countries. Russia the deepest, about 7 years lost over a period of 5 years in the country. These are reports that are very recent. Now, we don't know whether this is right, but I've been watching these things for like 30-some years, and no demographer, especially of his caliber, Olshansky, has ever said in the U.S. we're going to lose life expectancy. 150 to 200 years it's been going up here. And now the prediction is that it's going to drop. Maybe wrong, I don't know. Here's another indicator. Equality. As the wealth and globalization and whatnot went on, we got closer together in income. We got closer together from the 19th century all the way until 1973. This number kept going down steadily and steadily. This is inequality dropping. We got to the most equal point right there in the late 60s and 70s. This is a measure, the Gini measure, which is comparing the top and the bottoms to see what the spread is. And as you get more middle class, more people who are doing okay, the thing comes together. And it happened all over the world as well. We were getting more equal. That stopped. The inequality started and it's continuously gone this way. Not clear what that means, but there's a bunch of literature which says when this changes, social trust drops, cooperation drops, people stop voting, different kind of social impact. I don't know. It's an interesting possibility. One of the things about this whole change we have seen, and this is all data, but there is the human side of it, the rise in life expectancy and health, which I like the lines of Stephen Jay Gould, who has written about arguments he's had with people on these topics. He says, if anyone tells me he would rather have lived a century ago, I will simply remind him of the one irrefutable trump card for choosing right now as the best world we have ever known. Thanks to the public health and medicine, people of adequate means in the industrial world will probably enjoy a privilege never before vouchsafed to any human group. Our children will grow up. We will not lose half or more of our offspring in infancy and childhood. We will not have to sing the songs on the death of children or hire the daguerreotypist to take the only image of a dead child as it lays before the funeral. It's a different time. We have never lived through a time like this. The things we are experiencing, no generation has had. So that's the backdrop, the big picture. I want to jump to the details of some things that I saw. This is, I tell a few stories about classic cases in health. and development in countries. The Bengali Story starts on the night of November 12, 1970. Hurricane, monster hurricane. It is actually said to be the biggest natural disaster in human history. 500,000 people, it's estimated, were killed. The storm came up through the Bay of Bengal in the middle of the night at the time of high tide, 20-foot storm surge, 175-mile-an-hour wind, and the people had not been warned. Bangladesh is a very low-lying country. Massive destruction. The president of the country, at the time it was part of Pakistan, the president of the country was not in at the time. He was visiting, he was on vacation. And when the storm hit, he didn't actually come back right away either. This was the low end of the country. People weren't really all that concerned, the president included. What followed, there was already anger. What followed was riots, and then a civil war. And within a year, East and West Pakistan were at war, and India intervened, and that was this double catastrophe created Bangladesh. The people who, there were a number of people who rose up out of Bangladesh. They had quite a good educational system at the very top, became executives in international companies, were in fairly good jobs. A lot of them, relatively speaking, came back to Bangladesh and decided to take a break from their careers to try to help out. Hauling materials to rebuild houses, building medical stations, doing what they could to start over again. One of the groups was led by Fazl Abed. They got a committee together, and they did this emergency aid thing for a little while, but then realized that the emergency aid really isn't going to do all that much, all that long. Because before the storm and before the civil war, there was zero growth in Bangladesh. Very high infant mortality, very high mortality, high corruption. Very little was getting done. It was a mess. And Henry Kissinger said at one point, called it an international basket case. Probably the worst place in the world at the time. But they wanted to build a nation. I mean, this is where they lived. This is where their families were. So they put together a thing called the Bangladesh Rural Advancement Committee. He's an accountant. He's not too good with the words, which was shortened up to BRAC. And they decided to try to do something. There were too many things to do, so they spent time picking the one thing that would have the biggest impact immediately that was doable. What they picked was diarrheal disease among children. At the time, it was one of the two top killers. The children in Bangladesh then and now get diarrheal infections pretty frequently, once a month, once every 2 months, and every once in a while a really severe one hits. And this is many organisms. This is Shigella, cholera, rotavirus, all kinds of places, all kinds of different things attacking the children. The real problem is not the organism. It's when the organism starts dumping the water out of the system, causing the diarrhea, massive diarrhea in some cases, to the point where the water loss from the cells are just pouring the water out, causes collapse of the tissues, collapse of the veins. So you go from hydrated and then you start sinking back and then you get gray, and then in about a day and a half. About 50% of the kids who had this kind of severe diarrhea died at the time. There was a cure. There was a cure in Bangladesh, in the hospital in Dhaka. What that was is an oral rehydration solution, water, a precise amount of salt and sugar, in an IV bag on a pole, with a sterile tube and a sterile needle that you put into the arm. A nurse, the doctor diagnoses and instructs the nurse. The nurse watches and follows the treatment and tries to measure out how much is going in and how much is coming out. over a couple of days, you can save the life of the child. In fact, the rate is less than 1% of death, so 50% down to 1% if you put them on an IV pole. Not too many IV poles in Bangladesh. So these guys decided to try to bring the science to the villages. The idea was to have the village women, the mothers of the children, make the solution and deliver it to their children. So he went into his kitchen and he started making up batches with a pinch of salt, which is in Bangladesh is done 3 fingers, and a fist of sugar, which you fold over and then you scoop sugar, and then a half a seer, which is a tin cup of water. You put them together. You have to get it just right. So he tested up, went through lab tests, one after another, to get the right proportions that you might make in the home from local sugar, local salt, and water. Then they tested it out with mothers, instructing them the whole process about diarrheal disease, how to make the solution, how to deliver it. You have to feed it a little bit at a time over hours. Then they tested it out under controlled circumstances, and it looked successful. And the doctors in Bangladesh were horrified that these guys were going to try to deliver medical treatment through the illiterate village women. They protested against it. The WHO sent a team down and tried to stop the process and instead do an anti-diarrheal program through the government. Then the arguments started between the government and WHO, and the money didn't arrive, and the clinics didn't work, and so they went ahead. They started training up women. During the first year, they trained 58,000 women in villages with teams of 6 people, a few days in each village, and then moving on. They successfully trained them in the ideas and also to make the solution, and they took the solutions and tested them continuously with the labs to make sure they were in the right range, because too much salt and you kill the kid quicker. Too much sugar and it has no effect at all, which is about the same thing. And they succeeded at that, and they were really pleased until they went back and checked one more time and found that while the women could do it, only 6%, when the time came, when the baby was sick, did they actually use it. The mothers who knew how to do it. So they said, what's going on here? So they got a couple of anthropologists from the university to go out into the villages and talk to the people, and they came back with the not too surprising message that, well, it's not actually the women making all the decisions. The brothers are saying, and the husbands are saying, and the local healers are saying, this is second rate. We know those bags in the hospital. We know the Western style, and this is just second rate and crude. And so when a kid gets sick, they send them to try to get nearest pharmacy, whatever, some kind of Western style medicine. So the next step was to send the teams out and talk to the men, talk to the healers. And they had a whole round of that. And they went one step after the other. And they found that at some point the people teaching the women, the volunteers who got to be eventually semi-paid volunteers, kind of lost enthusiasm, and they became kind of rote teachers. And then the success of the thing dropped, and so then they had to retrain them. Then they had to put in a new system of payment so that after a volunteer went out and taught women in the villages, they leave and a monitor goes back in, does the testing of the women, saying, so how do you do this? Tell me about how it works. Give me the solution, let's test it. And they paid the volunteers on the basis of how many women succeeded. That really pushed the numbers up. So eventually, it took 9 years. They trained 13 million women across Bangladesh. It got to be essentially standard part of the culture. And across Bangladesh, instead of just in the hospitals, the rate of death dropped from 50% down to near 1% in severe diarrheal disease, a major gain. And it was basically saying the women may be illiterate, but they're not stupid. And these are their children in their villages. And you can train them, and this is what Abid said, you can train them, and if you fail at the training, it's the trainer's fault, not the woman. And so they kept on that theory, going back and back until they fixed things, until it worked. And then out of Bangladesh, it went elsewhere. Gradually spread around the world. It's fairly standard now. The drop, it's, I guess, more than half of the countries now use it routinely. There was a big cholera epidemic in 1991 in Latin America and Mexico, in which the death rate was below 1% because they used this. They got a break at some point. Somebody made little packets so they didn't have to mix it with the salt and sugar. The little packets are very cheap. Makes it a little bit easier, but it's what's used. So now, from the time the end of this program happened, when there were more than 5 million children each year dying of diarrheal disease, there are now 2 million. So that is technology transfer. BRAC didn't stop at that. They kept moving. They went to another project, vaccination. Bangladesh, 2% when they started. 6 diseases you could give vaccines for that were successful, and in Bangladesh, about 2% of the children were getting them all in the city. So they made a deal with the government. The government stood aside, and they would do it, and they pushed it up to over 80%. This is a scene from another thing they did. This is microcredit. The idea here is you go to the bottom of the society. Nobody can get collateral or loans, needless to say. You don't let middle-class women or people. You don't let anybody with property. This is only the poorest and only women, is what they started with. They do let a few men in now, but still mostly women. The loan is like $100 a year. You borrow it, you buy a cow, or you buy a couple of chickens. One woman I talked to, her husband used to pull a rickshaw, but he was fired from his job, so they bought him a rickshaw. So now they had a transportation company. You pay it back over 1 year. And this is the meeting you have every week. You have to pay some back every week. And you can see there's some peer pressure here. The rate of payback is about 98%, much higher than regular loans. So this is microcredit. It obviously expanded. BRAC and Grameen Bank were the 2 earliest, and now there's about 8 of them in Bangladesh. There are other places. They now have village health workers, again, now to do things like TB, monitoring TB, catching TB, and getting someone at the clinic to treat it or treating it themselves, depending on the situation. Various other kinds of treatment. Prenatal care is now done by village volunteers. They have gone into bigger businesses and so on where if you have cows and you want to sell your stuff to the dairy doesn't give you a very good price and all that, so they decided to make their own dairy. And so they took their own folks from the villages and they put the milk together and now are selling their own brand. So at the beginning of this whole project, there was about 80-90% was donor money. Not a lot of money, but it was donor money. It's now 80% their own money and only 20% donor money. And these women now have about $300 million in savings in Bangladesh. This was one of the projects they have got now. Girls didn't go to school much, and when they did, they dropped out. It wasn't highly valued to have a daughter with education. So they decided to start schools just for the girls who dropped out. No boys. They do, as you can see here, they now let 1 or 2 in. But basically, it's the girls in the village who aren't going to school. There are now 2 million of these young women in the schools. They're very proud of their schools. Almost all of them finish, a very high rate of going on to higher education, or going into what they've built after this, which is local clubs to discuss issues. So this is a model for delivery and development, delivery of health and development of a country. It's probably the most famous case. There are many others actually like it in different kind of areas. The oral rehydration project took 9 years. It cost $9 million. If you wonder about the effect of this on society, the BRAC offices have been bombed a number of times by terrorists. Fazl Abed has been threatened, and there have been assassination attempts on him. This is a Muslim country, and these activities create problems, especially because they're centered around empowering the women. But what has happened is the society has suppressed those and has essentially put them down, saying, whatever you think about this issue about women, these are our people, and this is a rise. This is us coming up. So we don't need any of this bombing and terrorism. And they've been protected. From the time they started till now, zero growth rate. Bangladesh is up over 5.5%. Death rate of children up to age 5 was up around 270 per thousand. It's now down around 68. The immunization is up at 80%. The number of children in school, public and private schools, is now 50% boys and 50% girls. Vitamin A. This thing started out with a scientific experiment. All these basic programs and delivery of health things start out with some scientific information. The oral rehydration. This one is vitamin A. They started out delivering vitamin A to get rid of night blindness in Asia. Women and young boys in particular who at dusk would go blind from lack of vitamin A in their systems. It was called chicken eyes in the area because chickens can't see at night. And so the women and the boys who were working, the women who were supposed to be delivering the meals and taking care of people, suddenly at dusk were out of action. It was very debilitating for the family. They did an experiment, and with 20,000 families delivering vitamin A to one and having a whole set that they hadn't delivered it to yet because they hadn't got there. And they compared the two, and they were going to look for night blindness, but there was a problem because the ones who had got vitamin A, they were all there, and then those who had not got the vitamin A, 30% of them were missing. So they went back to look what was going on. Where did they lose these people, and why only the one side? It turned out what was happening was the vitamin A was protecting them against infection. And they went back and searched in the literature and realized they should have known because there was a 1930s paper that showed that vitamin A can protect against infection, diarrheal disease in particular, various other kinds of infections. So in Nepal, they built up this program planned to deliver to everyone in Nepal 2 drops twice a year of vitamin A. They had done several large experiments to prove that it was the case. A 30% drop in mortality of children just by delivering these 2 drops. They were ready to go, but they could not get the government and the clinics to make it function. So they built an NGO. The Nepalis, led by this guy, Ram Shrestha, started, instead of delivering from the top down and government money, delivering from the bottom. What he found, he had been a volunteer across Nepal for a long time, and he knew that the people who had the time and the energy to do this were the grandmothers. So he went out and recruited grandmothers, 49,000 grandmothers in their villages. Each one, twice a year, has the kids come from her own neighborhood come and get the drops. And he built this thing up, bit by bit. The grandmothers, who were nobody, obviously, they were really the end of society. Nobody had much use for them. All of a sudden, they start getting some status, and their position changed. And now they're starting to deliver TB treatment, worming treatment, iodized salt. They're becoming kind of the health center of the village. They're still volunteers. They don't actually get paid wages, but they do get other benefits. They get, if their grandkids are going to school, they normally have to pay for books or fees. They get that discounted. Don't have to pay. And they're also, the government is, because he has pressed it, has said, if we have these people doing this, why don't you put a few bucks in the bank? They don't have to have access to it. You put the bucks in the bank, and then it'll build up, and over time, they will be able to draw on it, small amounts, to have parties, to buy a sari, to have small amounts of something, or to keep saving it, and to use it to deliver something to the village or to the women. Anyway, it's all across Nepal now. Nepal is, I guess you call it corrupt. The government is in bad shape. It's near civil war conditions, the high poverty, very bad conditions, but the death rate dropped after the widespread delivery of vitamin A, and will drop again after they deliver some of these other things. This is one of the kids that we were out, and the night blindness is not very common anymore, but we found one, a boy who had it and who was ashamed. We came by near dusk, and he was kind of hiding out in the corner, and we said, we tried to interview him. He didn't want to be interviewed. You have night blindness? No, I have no problem. But the kids were shunning him because evening is the only time they get to play. They work all day. Evening they get to run around. He couldn't run around. But he got the drops, and it takes only a day. So this is him back at his family job, which is quite a prestigious job of riding the water buffalo. Botswana. No wristwatches. This is a reference to a quote by Andrew Natsios, the head of AID, who, when asked about delivering ARV, anti-HIV drugs to Africa, said, it's a very dangerous idea to deliver these sophisticated medicines to the Africans because if we deliver them and they don't take them, resistance will build quickly and it'll be a waste, not only for Africa, but it'll come back on us. And his argument in Congress was, listen, these people don't even have wristwatches. They don't know how to tell time. How are they going to take medicines, several different medicines at different times of day? The drugs also at the time cost between $10,000 and $12,000 per person per year, which meant nobody's going to get them anyway. But Merck and Gates, Merck the pharmaceutical company and Gates the foundation, put together a project after many years of doing little AIDS projects all over the world. And some of them succeeded, but they didn't feel like they were really making progress. They decided to take a whole country and deliver AIDS top to bottom. Education, prevention, treatment. Just at the time this was going on with the idea of trying to deliver HIV drugs, ARVs, to Africans for the first time, they had almost none. They picked Botswana because it's very small, because it's also got no corruption, relatively speaking. That is to say, it's less corrupt than the U.S., in my belief. They also had a fairly good road system. They had clinics in every village. They had schools. The literacy rate is 80% in 2 languages. Small, rural country, but functional. But the worst AIDS in the world, 38.5% when I arrived. So the idea was to go in with this project and try to deliver the full scale of AIDS things and turn the country around. It's more difficult than it looks. They had a plan of 5 years, and they were going to start doing the things and having successes measured in the first year, and nothing happened in the first and second year. They ran into a lot of barriers, a lot of cultural barriers, difficulties. But finally, they did end up putting in every major area in the country, most of the villages or clusters of villages, clinics, and they did train all the nurses and the pharmacists. They trained the doctors to deliver these drugs. The president of Botswana was the one who insisted on having the drugs. They had thought, well, maybe we do the other things and maybe not the drugs right away. He said, absolutely not. We want to deliver these sophisticated drugs to all our people who need it free. And they were available for 3 years, and nobody showed up. The problem was that the people were afraid of getting tested. The very huge denial, very like the kind of denial we had in this country in the first years of HIV. So nobody came out to get tested. And there were cases, there were a few thousand who got the drugs and who came back essentially from the dead, got up off their pallets and walked. But until they changed their habits about testing, you had to go through the standard Western procedure, which you come in, you have your initial interview, you have your counseling, then they ask you about your family, your husband, your wife, your grandparents, your kids, then you have to come back with them, and you go back. It's a process that is really daunting. And it was built in this country. I was there and covered it. It was built in this country because there was nothing to give the people that you were testing and putting them at risk. If you test, you put them at risk of being found out. But in Botswana, they were offering the treatment and follow-up free. So they changed. They went to a routine system. If you go into the hospital, you have an infection, they test you. Okay, I'm going to give you a test for your blood count on this and that, and I'm going to give you an HIV test. Any problem? And then you moved on. And so it flipped from less than 8% of the population being tested to over 90%. And the delivery of the ARV drugs went from a few thousand to up. It's about 60,000 now in the country. The largest percentage of any delivery of ARV drugs in any country in the world. They have a total population needing the drugs of about 100,000. They have an actual possibility of getting there. Free, full treatment. This is Botswana Main Mall. This is one of the problems with the disease, is it's invisible. This is the main problem with the disease, really. That if everybody had sores, it'd be one thing, but the people who they're healthy and they're fine, and then they go back to the huts and they lie down and don't come back out. The main barrier to testing was psychological, very difficult to get through the sense that you are one person one day, you know who you are, you have friends, you have a job, and you walk into the testing center and you come out a ghost. People won't deal with you, your husband will throw you out, the family says you are shaming the family, etc. It's very bitter. But it has been broken through now, that barrier in Botswana. It's not ideal yet, but the change has happened. This is Edwin and his wife. They're both positive. They both resisted testing. They got tested. Eventually, he was positive, she was positive. His first wife died of AIDS, and his first child died of AIDS. She was single. But then they met at an HIV support group, and they got married. They're both positive. They're both in the ARV system, but are still too healthy to actually take the drugs. Now they have a child, 18 months old, who is negative. Presents some problems, but it's a different kind of life. There is life after HIV in Africa. After Botswana, there are now 15 countries in Africa that are starting to deliver ARVs at larger scale. And the way the delivery happened, even though it looks like a top-down program, money coming from the top, the only way this actually worked is when the village people came in, the chiefs came in, the doctors and nurses were trained, the Western doctors left, and the people there delivered the treatments. So that what started out as top-down became bottom-up, which is the case across all these programs, that the people in the villages have to do this. It has to be theirs. Polio, in the 1980s, the last time we had widespread polio, it had been knocked out in not North America and in parts of South America, not Europe, Africa, or Asia, but there were still, in the 1980s, hundreds of thousands of cases of death and disfigurement from polio. They decided to eradicate it from the planet like they had done smallpox. We got down to 2001. We got down to only 6 countries left with any polio, and a total of about 200 and some cases in the world. This is a case of polio in India. This is in Aligarh in northern India. Problem was, when you get down to the last few cases, you're in the worst neighborhoods and the people who are the most abused. And in this case, this is a Muslim neighborhood in a Hindu country. And the Muslims were, let's say, ignored. They're supposed to have a district health officer. The doctors are Hindu. They don't show up for the post. They won't go to this area. The people get angry, needless to say, and there's this big fight between the Hindus and the Muslims. And so at one point they decided they were going to refuse to deal with the polio. They would not take any more polio volunteers coming through saying, so why are you paying attention to polio? What about the diarrheal disease? What about TB? What about all the things that are killing us every day? What is this polio thing with you people? And they decided it must be something different. There must be, you're trying to sterilize us. So the rumor spread quickly around India. It jumped to Nigeria. And quickly, the Muslim neighborhoods in Nigeria and India refused to go along with polio, and the 200 or so cases we had left shot up. 500, 800, 1,000, 2,000. And then they had to go back into the neighborhoods, and they had to talk to the people about what was happening. They said, the volunteers who come through here, they're men and they're Hindu. They knock on the door and ask for the Muslim women and want to come in. They don't talk to us about our health care. They don't talk to us about anything. So they went through this thing of working with the people in the neighborhoods that were the problem. And they finally came to agreement both in the villages in India with the Muslim clerics and in Nigeria, and the program is back on track now, although now it's not 6 countries that have it, it's 20-some countries. Indonesia has gotten a dose. Countries that had been clear for 4 or 5 years are not, now have polio again. But if they're on track, probably next year or the year after, we will see no more polio. This is an anti-polio march, and this is a sewer. This is the school right over here. This is where they play. And this is the neighborhoods where they have to knock on the doors. This is an unmapped neighborhood. So you have to knock on the doors. They have to make a map of the neighborhood. They have to name all the people in the houses, say who they are and what their ages are, because there are no such records except for the polio volunteers have them. So those are some stories from the countries about things going on. At the time I was doing this, I had picked 8 places to go where there were interesting projects. When I came back, I found there had been just a study published about projects that were successful in third world countries, that were successful on a very large scale, that had endpoints that were mortality, not secondary endpoints, but actual reduction of death. And that they were inexpensive. I think the limit was $100 per DALY, what they call a DALY, which is a disability-adjusted life year. That is to say, if you save a life or you save from somebody from a disabling injury, that's counted. $100 per life saved, basically. If you look at end-stage cancer, it's $1 million to $10 million per DALY. So a vaccine is down in the range of maybe $20 per life saved. Really big leverage programs. That project found a lot of those things. They had to be national or international scale. They could not be small projects. They found 17 and published them, and they were in addition to the 8 that I found. So these things are out there. And they all have very similar features about how they happen, how you succeed. You have to adapt them locally, obviously, but there are some features that are the same. In this country, there's been, at the same time these things have been going on in these other countries, there have been data developed about issues of development, that new approaches, new data that is related, that is especially important for Americans. This is the State Failure Project, University of Maryland. Also, the CIA helped with this. This is trying to figure out what makes states fail. They took all of the cases from 1955 to 1998. They've actually extended that now past 1998. And they looked at all the things that were going on in the country, and they tried to figure out what were the things that were correlated with the failure. And the failure is regime change, coup, ethnic cleansing, various kinds of disasters in the state. They found these events, and they also found them increasing from 1955 to now. The most important factor was the fairly obvious one, regime. What is your regime? What is your government system? And they found that the dictatorial regimes and the stable democracies were both fine. They almost never had a problem. The problem was with beginning democracies. They were most at risk, the most likely to fail. And one of the predictors of failure was having an election. Having an election before you have a parliament, before you have anything in place, having an election is a really good sign the thing is going to fail. That's kind of interesting, but it isn't the point, because we knew regimes are the measure, but after you get past regimes, the next thing, a really sensitive measure of trouble, of a country coming apart, they thought it was going to be GDP per capita, wealth. That didn't show up, had no relation, because it doesn't say anything about, you got wealth per capita, but it doesn't say about the top and the bottom, how far apart, etc. Infant mortality was the single most sensitive factor predicting state failure after regime change. Because it's about education, it's about health delivery, it's about fears of the parents, it's about all kinds of social things brought into one case, the infant mortality. Global incidents of revolutionary war going up, incidents of ethnic war going up. This is a time when after the Soviet Union things are supposed to be quiet. It's not quiet. In the U.S., infectious disease has been dropping for a century, up until 1980, when it started going back up. It's going up 5% a year now, and it has been since 1980. There are new diseases and returning old ones. Here's a returning old one. You can see this drop is continuing on, and then in 1990, suddenly 28,000 cases in New York. That variety of TB was from Russia. The Russian state collapsed. A lot of TB, it hopped over to New York. Vulnerable people. The health surveillance system had been dismantled in New York. People had been cut back. Then in order to push that back down after the huge rise, the 28,000 cases, it cost a lot of time and money. They pushed it all the way back down, except now there's going to be pockets permanently, as far as we can tell, and places from which it will rise again. It didn't go down in this group. Foreign-born persons in the U.S., it's going up. It's a pocket now. Asian tiger mosquito. This guy was not in the U.S., and the other carriers of dengue fever had been eradicated about a century ago. Prior to 1981, 81 to 87, 97. The arrival of the tiger mosquito. As you can see, the next few years after that, it goes into the U.S. We have it back. Dengue fever. DHF in the Americas. Affected, unaffected. Reported cases in America, 70s, 80s, 90s. It's not just America, it's rising elsewhere, and it's a new form. DHF is dengue hemorrhagic fever, which is much worse. It's like Ebola. It's a total bleed out. It's multiple dengues together at the same time. This is how it arrived in a shipment of tires from Japan to a port in South America. Inside the tires, water gets inside, and it doesn't matter what you do with the tire, the water stays in there. It could be this way, it could be this way, there's water in there. Mosquitoes love that. So they rode from Asia to South America in these tires. Not these tires, but in tires. So what we've got is more than 40 new diseases have appeared, and 20 old ones are rising again. We don't know of any period in history that is like this. These are some of the new ones and old ones that we have. Dengue fever is back. Ebola is new. E. coli is new. Hanta, HIV, Lassa, Legionnaires, Lyme are all new. Mad cow disease, malaria is coming back. And avian flu. which is more recent. This is what we're dealing with now. It's in birds, but this is also new. New variety of an old thing. In economics, also new information. Because of what we saw earlier, the idea of wealth, if you wanted to start and develop a country, you start with wealth by putting in money on roads and factories and whatnot, capital investment. It turns out that was a mistake. That's the wrong picture. That's only half of the picture. You start the most basic item, and the reason for the Asian miracle was starting with health. If the kids are healthy and they start growing up as workers, and that's the beginning. A revolution in economic thinking has taken place over the last few decades, putting human capital on a par with physical capital as an input to production. Long life expectancy may be the fundamental force that creates the demand for education. Perspective offers an exciting new possibility in international development, investing in health to stimulate development, which is the base of a current global health movement and the demand for more funding for health aid. In these things we've been talking about, the central new factor is health. What its effect is in national security. The CIA, the National Intelligence Estimate, Colin Powell and others have said it's a central factor now in national security. We have to pay attention to health here and health in other countries. In the economy, the rise of disease, globalization. So the plans on the books are we have signed on to the Millennium Development Declaration saying we should deal directly with health, and we got after the declaration, we got details of the projects, what should be done, what the goals should be, and then after that it was spelled out in detail how much we would have to spend to do the basic things in each country, only the highly leveraged ones. The simple, inexpensive ones that the treatments are waiting there and we can deliver them and we can have a significant mortality impact. They counted them up. They counted out what it would cost across the developing countries. And they have started a fund to deliver the money, the global fund to fight AIDS, TB, and malaria. And its method is results-oriented. It's monitoring the money so it does not go to corrupt governments. You can deliver it to an NGO. You can deliver it to anybody. If you deliver it to somebody and they start stealing it, you take it back, and they have done that already a couple of times in Ukraine. They started delivering money. The government started taking it, and they pulled it back. They stopped the program. They did it in Uganda. They were delivering ARV money in Uganda, and the government started stealing some of it, and so they stopped the program, which was very sad, but the people in the program who were delivering the ARV said, we have no choice. This does not work if it's going to be stolen. We agree. Take the money back and do it right. So that's all reasons why we're at a crucial moment where we have a lot of technology and methods and things we can do to change the mortality, the health situation in countries around the world. And there's another one that I read recently. Neil Ferguson, conservative historian at Harvard, says, remember back to 1915, we had globalism then. It was going very well. Nobody believed it would stop, because everybody was relying on everybody else. But all of a sudden, war broke out. Globalization stopped completely. After the war, there was total lack of cooperation internationally. There was high tariffs put on. The League of Nations was starved to death, and so was the precursor of the WHO. No cooperation from the countries. They wanted to be sovereign. The fiscal problems ended up in depression and a second war. So it was a total collapse from globalization, where everybody believed it was going to carry on, So then after World War II, when Europe had been devastated, poverty, the factories were working, the farms were not working, they had started putting in aid and it was not working. They thought Europe was going to look like the Third World. It was fairly clear that they did not want to do what they had done in 1918. So they built the Marshall Plan. Marshall Plan was the sense that there were terrorists in Europe. They called them commies at the time, but they were terrorists as far as they were concerned. And they were succeeding, and they were succeeding because there was desperation in Europe. There were riots, there were revolts. And the Soviet Union refused to cooperate in trying to make peace. And these guys, George Marshall and others, agreed and have written about that what was going on was they needed the unrest. They needed the war. They needed trouble in order to move on, in order to get country after country into revolt to change their systems. So they built the Marshall Plan, which was a plan essentially of aid. A country tells you what they need, you give it to them on a huge scale, a scale we had never seen before, for about 5 years. It's now considered the most successful development project ever. It had some of the same features as some of these things we see now, but have been forgotten. Like, we don't tell them what they need, they tell us. You monitor the money and so on, but so this is Churchill saying, this huge amount of money that we're putting out there is not charity, it's an investment. What is Europe now? It is a rubble heap, a charnel house, a breeding ground of pestilence and hate. This is not a philanthropic enterprise. It is based on our views of the requirements of American security. We confront extremism not with arms or atomic bombs, but with a restored economic life for men and women. The force of hope will build societies. So here's some current guys on the same topic. Every time we get this is Gates Foundation. Every time we get a grant proposal, we ask what fraction of the problem will be solved by this work? Always. If there's no answer, there is no grant. This isn't about compassion, it's about results. It is not some sort of well-meaning hippie stuff. Bono. So we're at a moment of choice, and I wasn't aware of a lot of this history and a lot of these things going on, and the fact that we had the possibility of delivering really successful aid programs in health, directed aid programs, and that all the details had been worked out to make an attempt at it. And I had never seen in detail how they worked, how well they worked, in the BRAC and other programs. So I came back very hopeful, but also a little bit scared, because it was unclear anybody was paying attention to this. This is not on the agenda. So I want to read as a closing item a quotation from Winston Churchill. At the moment when he was pleading for the Marshall Plan in 1948. If we allow ourselves to be rent by petty disputes, if we fail in clarity of view or courage in action, a priceless occasion may be cast away forever. But if we pull together and firmly grasp the larger hopes of humanity, then it may be that we will move into a happier, sunlit age when the children who are growing up in this tormented world may find themselves not the victors, nor the vanquished in the fleeting triumphs of one country over another, but the heirs of all the treasures of the past and the masters of the science, the abundance, and the glories of the future. Thank you. So if you have any questions, feel free. This is this book and the PBS series are sort of an attempt to take these issues and put them on the agenda, mainly because there's one thing that is going on that is particularly difficult to deal with, and that is Americans have the sense that we are spending huge amounts of money on aid and it's going to waste. In the polls that have been done over the past 10 years, people believe that 25% of the entire federal budget is going to foreign aid. The actual amount is less than 1%. And when you follow up and you ask, so this is the actual amount. Now do you think we're spending too much? And the answer is no. We think more should be spent. People are willing to do it, but they don't know. And so part of the idea of this project is to put these issues back on the agenda and to remind people that there's a reason to do these things. And we've gone through an era when we have stopped making public investments. And the rise, the sewers in London, the Marshall Plan, these kind of investments, the eradication of smallpox, these are the kind of things that have kept the life expectancy and robustness going, going up. And when you take them out, you can see, see the beginning of the crumbling.
I just wanted to congratulate you, first of all, for telling a great story. It's a story that needs to be told.
Thank you.
And you put together very beautifully. I look forward to seeing the series and looking more in the book.
None of it is mine. It's all other people's work. But I was really taken by the fact that it hangs together when you take things from these different areas.
Well,
and it makes sense.
Exactly. And you're the storyteller. So you don't need to be the actor. But
that's the plan, yeah.
That story and getting it out to people
Yeah.
and changing the mindset that investing in health is really ensuring our own well-being, I think is so fundamental.
In economic terms, if you want people for customers, they can't be dead. They can't be sick. Or the other way around. If we're going to be the customers, they have to be up and walking around. If we're going to be cooperating, if we're going to be talking about peace and things, they have to be alive. And it's the fact that it's not on the agenda is a major problem, but it was also the problem with the Marshall Plan. In the beginning, the first polls showed that nobody wanted to do that they thought it was throwing good money after bad. They had already spent money for 3 years and got no help in Europe. It was not working. They thought it was a complete giveaway until Czechoslovakia fell. Then they said, you know what, maybe we do need to do this in order to save Europe. And maybe all this stuff they're saying makes sense. If you put the money in, it actually works. So unfortunately, that tends to make one believe that what we have to wait for now is another catastrophe in order to put this on the agenda.
You mentioned a couple of different programs from some countries, but what kind of cooperation are you getting from from other countries, period, whether it be from the country you're working in or from other developed countries contributing money to these types of programs?
Yeah. I personally have it very easy because I'm just a reporter. I just fly in and start talking to people. And the governments that I have, in Bangladesh, for example, this is a place where the government is still corrupt, but the country is rising up underneath it from NGOs, from the village women, working on their own. The government is standing back because they're getting some credit for it when the vaccination level rises up to 80%, looks pretty good for them, but it's still a corrupt government, so it's happening underneath them. So you talk to the people in the Bangladeshi government, they're cooperative. They say, well, we have clinics, they're helping out too. We respect BRAC. We're there too. They don't react badly because they're having success. So the corruption itself, the problems with the government themselves, we have realized you don't have to run straight into it. With the Global Fund, the plan is when you want to deliver money to a country in a big way, you do not go to the government. What you do is you require a group to get together, including teachers, ministers, NGOs, from all over the country. You have the government sit at the table, but it's a committee. And they come up with what the project is, they make the proposal, they deliver it to the Global Fund, and it goes from there so that nobody dominates it. And when the money goes in, it doesn't automatically go to the government. It may go through the government if it works. And they have results. They say, okay, 2 years out, this is what we want to see. If this is not here, it comes back. And it's had quite a stimulating effect. They've already put out $4 billion. So these things are kind of like from the ground up, they're happening. And the countries are going along or not going along. The U.S. in particular. The Bush administration has actually put more into foreign aid than the previous 3 administrations, but it's still kind of scattered, and it's put in a way that is not all very well directed. So it's they're of two minds. There are some people in the Bush administration that really want to do this, and some that don't. So the hope is that at some point this will get on the agenda, it will be up there, and it will be to the credit of the administration to take a program like this and do it. The money that's going into the Global Fund, most of it is from the Bush administration because they like the idea of an entrepreneurial NGO that's not connected with the UN or the US. It just operates on its own to deliver the money and get the goods. So they were encouraging it. Now it's unclear whether they're going to make more payments. So we're like this all the time. And that's why it's both hopeful and scary. Because I think the collapse in 1915 is something that is not impossible now. The globalization doesn't look all that strong to me out there. It's rolling very fast, but there are big problems with the gaps, big problems with anger. And I think troops carry us only so far. These kind of things have to be there too. So the cooperation is not yet there, but the Europeans, the Germans, the French, the British have all committed to increase their aid to a high level. That is to say, a level we all agreed everybody should put in, 0.7% of your GDP. They've all agreed to go the whole hog. The U.S. hasn't agreed yet. The U.S. is down at 0.16, so they'll have to quadruple to get up there. They haven't disagreed yet, but they said they will increase, but they won't say by how much. So I don't know. I would say we're going to have to wait a few years and have people talking about this as a possibility for a new approach to policy, in this country and abroad.
Yeah, I'm glad you just mentioned this country because I'm from the Detroit area, and I recently heard, it's hard to believe, especially when you said the single greatest predictor of a state failing is the infant mortality, that the infant mortality rate in Detroit today is 30%. I mean, that's incredible.
Overall in the U.S., we've had infant mortality has been going straight down for a long time, until 2002. The first time in more than 50 years we actually saw infant mortality go back up across the country, which is a big, big number. And for that to change like that is pretty startling. The U.S. is not doing well compared to other countries on infant mortality anyway, but it's still been going down. But now the signs are all faltering. All the data is not looking good. It's like we spent the money 20, 30 years ago and we lived on it, and now we watch avian flu come in, and the people who used to be there in the public health departments are not there anymore. And the plan that we should have had to be out in the other countries watching for avian flu and working with them, if they're not there. So the reason avian flu is a problem is because we didn't do the work.
Could you briefly, I know you're not a scientist, but why all of a sudden are we being bombarded with all these re-emergent diseases?
Yeah, it's really interesting. The first and most obvious reason is globalization. The number of actual contacts between people is enormously higher. The number of people going from heavy-burden disease countries to low-burden disease countries is 1 million a week. Nothing like that ever in history before. The second thing is, when you go and you destroy forests, there's guys hiding in the forest. These are niches for a lot of organisms and the animals, and they come out and they start interacting. So you start getting the flow of genes, the flow of new organisms. So you have globalization. At the same time, you're pulling out all the organisms and mixing them together. And then the third reason is the biology itself. The main thing organisms do is they multiply and they change. And we've given them the opportunity both to multiply more and change more when we mix them into more organisms. So this is all predictable now, that you're going to get a huge number of new diseases and old diseases coming back. We didn't see it until fairly recently. 1988 was the first detailed report on it. But it's because those obvious big factors are going on. It's civilization, basically, is causing these things to happen. You put everybody together, people from Asia and the U.S. who hadn't been together, their bugs are different. You take the HIV came out of a forest. It seems different now. It was not different. SARS is the same. I mean, these are things coming out, new organisms, and old organisms coming back because we've let down our guard. But there are solutions. We have ways of dealing with these things. We know these things in detail enough so that if we set up the surveillance and we deal with these things internationally, cooperatively, it's possible to manage them. But right now, for example, food, we're now importing 3 times the food we used to import. Well, when we grew it here, we could watch the pesticides put on, we could monitor the organisms to see if they're diseased, salmonella on lettuce, whatever. When it comes from another country, we do not do that. It is not being monitored now. The FDA just got the authority to do it, but I talked to the guy who's in charge of the program. He said, we have nobody to do that. We can't send them to Mexico to check anything. So it comes in, it comes in. Naturally, the foodborne disease is going up in the country. Not surprising. We're not doing the work. It's not that we couldn't handle it if we were doing the work or were paying attention, but these subjects are not on the agenda right now.
I wanted to make a brief announcement regarding the bookmark that I've passed around. I'm Cindy Hock from the medical school, and my colleague, Professor Linda Bauman from the School of Nursing. We're pretty excited about launching our new Center for Global Health here at the UW. And this is a collaborative effort of the schools of...
You can stand up.
Well, it's a small group, but it's the medical, nursing, pharmacy, and vet schools working with international studies, working with area studies and social sciences to bring together expertise on campus and to really offer a program of study, courses, opportunities, a new certificate program that Professor Bauman has put together, and training abroad, study abroad for students who may want to get interested. So again, I'm pretty excited that your series and visit has coincided with our new center. We're pretty excited about how our program will evolve in the future. I'm hoping that the University of Wisconsin can really play a major role in an increasing role in addressing this.
If people in Wisconsin are going to be discussing these things, it's going to be because of groups like you getting together, doing the work, and drawing people in, making people aware. And it's not going to happen if that doesn't happen. So it's nice to see. I just show up here, and here it is.
Thank you. Well, you must have sent us a message.
Let me just point out that on December the 7th, it's a Wednesday also, is our Global Health Symposium. It's all evening, 5 to 8, and we're going to have some keynote address by Francis Wesley from the Nelson Institute for Environmental Studies about health and the Millennium Development Goals.
Yeah.
But then a series of presentations from faculty, staff, and students, and you'll see the great variety. It's a celebration as well. There'll be food, music, dancing. We've got an interested and engaged student group putting together some of this. So everyone's invited. Doesn't cost a penny. Please come and join in. Look at our website. You can join as an affiliate if you'd like. We'll keep up the dialogue. We've sent out to our listserv information about your show.
Great. And the book. You have to do the book. They're separate. But one note of hope is that the politics can get very bad these days. But this one hasn't yet. Because on the board of the Global Fund and in the administration, some of the evangelical Christians are the strongest ones on this issue. Because their tradition says, as charity, as helping other people, you do it. So that the other politics, we haven't gotten into the terrible politics on this one yet. So if we can avoid that and talk about just delivering these things and doing it like the Marshall Plan or like the Peace Corps in the way that Americans have done before, rather than whether we're left or right or what we are, it's still possible. Thank you. Oh.
Assuming that millions watch the show next week,
Yeah.
what would be your hopeful outcome of how this could proceed?
From looking at the history of it, I'd say that it took about 2.5 years for the Marshall Plan to get anywhere, and it got up to a point where people were more or less in favor of it when the catastrophe happened. So in this case, I'd say we have a couple years in which we have to start talking about this. And we have to start putting this on the agenda. People have to start writing about it. And there are some efforts to try to get newspapers to do more of this writing. It's very hard for American newspapers to commit themselves to write about things going on in other countries, having spent many years arguing about that. But the idea is we have to have some discussions. We have to make it political, on the political agenda at least. And there was a meeting in Congress on celebrating this event, and people from all sides came and started discussing it. Because it is still neutral, they can both be in. So I think it's the beginning of a couple years at least of discussion, and I hope it doesn't take a catastrophe to make it something we have to do. But I don't know how long it takes. I mean, I think the logic is there. If people can see it, it can be laid out and you can go over it. And the idea of delivering aid as an investment, not we're talking peanuts here, you know, we're talking 0.16 is we're giving now. We can go up to a grand total of 0.7 of our GDP, and that's all we're being asked. And so it seems possible. And I guess I'm hoping that the discussion will start and people will get in, and maybe we'll pull it off at some point in some form. I don't know. Okay. Thanks.